Today we are here for the discussion of the neonatal market report. So here Dr. Ajinkya, who has a pediatrician specialized in neonatal medicine. He has a vast experience in UK and India working in a various neonatal units. Currently, he has returned to country working as a neonatal consultant and also mentoring a government and a WHO-funded projects to reduce the neonatal mortality rate of India. So moving ahead, thank you for spending your valuable time. So basically, I and my team currently working on the neonatal market report. So your experience will definitely help us to what the real world challenge facing and what are the needs, what are the opportunities for the innovation in this field. So I really look forward to this insightful and interactive discussion where your perspective will directly shape our research and recommendations.
Okay. Yeah.
So first of all, do you have like any kind of for the starting, what is neonatal and what is the impact on this infant child? And
so what does neonatal medicine mean? What does a neonate mean? So neonate is a baby till 28 days of life after birth. So as soon as the baby is born, so in the womb, that's a fetus. After birth, that's a baby, which is called a neonate. So neonatal medicine is a study of newborns till 28 days of life. So this branch has really come up because we are saving babies earlier and earlier gestation. These are premature babies.
Correct.
So anything that is less than 37 weeks of gestation is a premature babies. For our parents' generation, 33, 34 weeks gestation babies were quite a danger, or it was a scare because they were quite premature in that era.
Correct.
But now we are living in an era where we are saving babies that are as early as 22 plus 6 weeks of gestation. So that is extremely premature. That comes in the definition of extremely premature baby less than 28 weeks. So this field has really skyrocketed in terms of definitely market, but also globally. All the governments are changing guidelines to save the gestations of earlier and earlier born babies. And India is a low and a middle income countries. So the graph is going up as well of the amount of babies that we are trying to save that are born prematurely. Having said that, neonatal medicine does not end at prematurity. There is a whole other aspect to it as well, because as I said, it is the study of newborns. So newborns have a lot of other problems as well. For example, they don't breathe at birth. So that is birth asphyxia. They can have infections in first couple of days. That is, neonatal infections is one of the biggest killer along with prematurity in developing countries and along with congenital malformations in developed countries as well. So the governments as well as the policy makers have to create a system and an infrastructure that will reduce the deaths because of neonatal infections and prematurity and birth asphyxia. Having said that, the fourth problematic situation with newborns, which is more seen in the Western countries, is congenital malformations. That is, something is wrong with the baby that is born. Some malformation is there either externally or internally. So neonatal medicine is quite vast. It is quite diverse. But it sort of deals with everything relating to a newborn baby.
Okay. So as you said, the biggest killer for the neonatal. So there are of course so many like you faced from your clinical and research experience, which causes contribute most to newborn death in India and globally as well.
Interesting. So India, as I mentioned earlier, is a low to middle income countries. That's what our description is on a WHO website.
Correct.
So in a low to middle income countries in India, which is as diverse with 29 states with lot of disparity between the socio-economic classes. The etiology, or it's a fancy term for a cause, the cause for newborn deaths varies as well. Okay, but statistical data dictates that as of now in India, or rather in the Southeast Asian countries, the biggest killer is prematurity. Okay, closely it is followed by infections, and then birth asphyxia, and then a small number of congenital malformations. Having moving to Western world, probably the congenital malformations are the biggest killer, I would say. More babies die because of congenital malformations and neonatal infections. Okay. Because of their strong referral system, because of their strong infrastructural system that is placed in situ for antenatal care. Antenatal care means antenatal period is before the baby is born. Okay. So since the infrastructure and the system is such that the care for antenatal period is optimum in Western countries, less babies die because of prematurity. But in developing countries, more babies die because of prematurity, and this is sort of a thumb rule. But let's say if we are sitting in a metropolitan city in India, the probability of a baby dying because of prematurity is less. If you go in the periphery, where the neonatal intensive care units are not as equipped with latest technological infrastructure or even an experienced staff, there the reason for death will still be prematurity. So you have to take it with a pinch of salt and really understand where a baby is dying when we make a general statement, oh, in India this is the biggest killer, or in the UK this is the biggest killer.
So of course there are so many other reasons as well for that.
Absolutely.
So as you said, for example, major causes like prematurity, birth asphyxia, and the congenital disorder. What exactly improvements would make the biggest impact or reducing this kind of death?
Yeah, that's a good question. So the rate of premature babies that are born has sort of flatlined for last 10 to 12 years. Okay, so there is no improvement in the number of babies that are born, and to large extent there is not much improvement in the number of babies that are saved as well. Let me go into the details of this. So a couple of years ago, the data that was published was around 13.4 to 14 million babies were born premature. As of now, in 2025, around 14.5 to 15 million babies are born premature. So statistically speaking, every one baby of 10 babies is born premature. So what is the reasons for that? The reasons are many. Most of the deliveries are spontaneous without any reason. Okay, there could be infections, there could be anemia in the mother, there could be some congenital malformation, there could be trauma, there could be a lot of reasons of why a baby is born prematurely. Is it worth going into details of this? Yes, definitely there is. So a very good antenatal care with regular ultrasounds, with blood investigations, with preconceptional health of a mother. What does preconceptional health mean? Before conceiving a baby, the mother's health should be optimum in terms of hemoglobin. She should be on folic acid supplements, because folic acid completely reduces the congenital malformations in relation to the neural tube defects, that is the brain related malformations. So going into the details of why the babies are premature, are born premature, is worth it. And these are few examples that I gave you. Okay, but let's come to the point that the baby is born. Baby is born prematurely. Then what we can do? Then again, there is a list of very simple interventions that can be done, and this can be done even in the remotest area of India, or even in the most plush metropolitan city of India as well. The cost of this intervention will not increase, because they are quite simple, as I told you. For example, what are the methods or the practices? Like, there is something called as kangaroo mother care. Just putting the baby on the chest as soon as the baby is born, that reduces the risk of hypothermia, that is low temperature, by 70%. It reduces the deaths by around 15%. Okay,
that's a nice insight.
Yeah, it's a very good practice to start and implement. Okay, that's one of the scale up programs that I'm working on currently by WHO. It is called IKMC. So it is an evidence-based practice that has been already established. Now we are just scaling it up. Okay. So this is one practice, I would say.
Kangaroo practice.
This baby now is admitted to the neonatal intensive care unit. Okay. Now after this baby is admitted to the neonatal intensive care unit, of course the structure and the infrastructure over there, including the staff, should be conducive for that baby to live on. So what does that mean? There should be good quality incubators. There should be good quality radiant warmers. There should be good quality monitors that can pick up the respiratory rate as well as apnea of the baby. That's when the baby stops breathing. There should be good quality ultrasound machines that will check the intraventricular hemorrhage of the baby, to see, because that is one of the common complications of a premature baby. And phototherapy machines, the medicines, the cannulas that we put in, they should not be of a bad quality, because that's quite harmful to the newborn skin. And the NICU has to be well equipped. That's not ambiguity in that, and so must the staff will be well trained to use these medical equipments, to the optimum level, because there can be troubleshoot at middle of the night. At 2 a.m. the ventilator has stopped working. The staff should know how to, sort of troubleshoot that and circumvent that, because there is no 24-hour support often from these medical companies, which is fair, So babies are born early. Babies are born premature. Sadly, for last 10 years, we have flatlined the amount of babies that are born premature. But we have improved in the care, that we are able to foresee what things can go wrong than we were 10 years ago. And the very reflection of all the international guidelines trying to save earlier and earlier gestation babies just demonstrates the confidence in the neonatal medical team across the world and the pharmaceutical industry to save these babies. In developing countries, it's a bit muddled statistics because of maybe poor reporting, and the country is so diverse as India. So less than 28 weeks, not all can make to be NICU graduates, as we call them, and to discharge from the NICU. But in the Western countries, or as they call high income countries, only 10% mortality is seen in extremely premature babies. So that's quite a good statistics. This also demonstrates the optimal training of the staff, the doctors, as well as the equipments.
So as we earlier discussed, the same thing, like you said, the product types, the monitors, the incubators. So I have already covered that as our segment. So moving ahead, whatever we are discussing right now, so I'm understanding this. The basic thing is awareness to the people and awareness to the team.
Yes, definitely.
So thank you so much for the this insight that 10% mortality rate in developing countries. But and whatever you said, like the incubators, monitors, and the, earlier, of course, we have discussed this, and I have covered this scope in my report as well. So now discussing, so what I feel, the awareness to the people and awareness to the nurse and all that stuff is very necessary right now. And of course, there is something like any kind of programs or kind of awareness program, I can say. So I believe that you also doing this kind of programs, or you are also conducting this kind of study to the India level as well and the globally as well. So can you tell us that? So
absolutely. So yes, awareness does have a lot of importance while we are dealing as a community of doctors as well as a general community to reduce the newborn deaths. So awareness can largely be on two levels. Number one is the community level. So the parents, the new parents, or even the grandparents, or even the parents of the parents who are becoming parents, the awareness should be amongst them as well of how good a health of a mother should be, or of all the girls in reproductive age group should be. So awareness starts from there. Maintaining their good health in terms of blood markers like hemoglobin, like thyroid, good sugar control, including the mental health and sexual health, So awareness really starts from there. This all has an impact on the newborn mortality rate of the country, because newborn mortality rate, if it is low for a country, that means many indicators are in the positive, are affirmative. For example, good health of the mothers, good mental health of the society as a whole, good infrastructure, good referral system, good vaccination programs. So a lot of things indicate are good when a country tells, oh, our newborn mortality is less. Because newborns are so sensitive, so they are literally the lightest feathers of the society that can take off when not taken care of. So newborn mortality rate, if we improve, then there will be a ripple effect in the society where a lot of things will improve, and an integral part of this is awareness. So awareness starts from prenatal period or even preconceptional period, and then we go to the conception. Okay. So this is the community awareness that I was talking about. It also includes awareness about how many visits should a pregnant woman go to the doctor, what is the tentative weight gain that a woman should have, how much rest she should take, how much calorie intake, how much protein intake, what are the red flags during pregnancy, what are the vaccinations that a pregnant woman needs to be completed, and also other logistical information like, oh, where is the hospital, where is the NICU, where is the parking of that neonatal unit, so more knowledge will definitely empower the woman as well as empower her family. Nowadays we are looking into family integrated services or family integrated care or FI care, because everybody is on the same team. Okay, so yes, awareness does have a lot of importance, and this is the community awareness that I spoke about. Now let's come to the awareness of the healthcare givers, so the nurses, the auxiliary nurse midwives, as well as the doctors, they should be made aware about the latest guidelines, about the latest practices, about the latest updates in the change of guidelines. Recently, there is a change in something called as the neonatal resuscitation program. So NRP is widely followed across India. So it has released the 9th edition. Okay, there are 13 changes that are there, and those changes are good changes, So the older pediatricians, newer pediatricians, older neonatal nurses, newer neonatal nurses, they should really read about that. So awareness in medical community comes from that perspective. You asked me if I'm working on such programs. Yes, I'm working on more or less 4 such programs. Number 1 is something called as Sankalp. So Sankalp is an ICMR funded project that deals with reduction of the neonatal mortality rate of the country. So there are 10 to 12 different sites across the country. I am associated with the Sankalp project that has been run in Varanasi. Okay, so we are trying to create a module that can be hopefully extrapolated in rest of the Uttar Pradesh so as to reduce the newborn mortality rate. The second one is something called as IKMC, that is immediate KMC. Okay, so I mentor this team, so as to improve the rates of immediate KMC, that is delivering the baby on the abdomen and immediately giving skin to skin, okay, within 2 hours. So that is immediate KMC. So that also requires a lot of awareness. It requires hand holding of the staff that has been delivering babies for last 25 to 30 years. The third and fourth are the programs that I have designed and launched myself for the benefit of Maharashtra. One is called as Ankur. So Ankur deals with very simple newborn practices that I'm trying to promote in the resource limited settings across Maharashtra. So I conducted one session in the very remote area for 10 primary health centers in Konkan, where all the staff was trained by myself and my team, okay, so as to implement, let's say, IKMC, birth preparedness, as well as delayed cord clamping. This is all the things that can reduce the newborn mortality rate. And the fourth one is called NLC, a course that I have designed, that is Newborn Life Care, so as to train the nurses across the country only in newborn care. Such a specialized training program, unfortunately, is not available in India. We do have MSc Pediatrics, but not something that specifically will give her a certificate to train into newborns. So I am involved in these awareness programs, and I'm hoping that there will be a snowball effect and there will be a ripple effect in the medical community as well as the community level in the society, and that will eventually lead to improvement in the newborn mortality and morbidity.
That's great.
Yeah.
It's really great to hear from you that you are helping in India to reduce the mortality rate by doing such kind of awareness programs. So, of course, then do you have any kind of right now any updated statistics such as incidences, cervical rates, and complications in India or maybe on global level?
Regarding the newborn deaths?
Yeah.
So as I mentioned, let's talk about Southeast Asia. The biggest killers that we said are prematurity, neonatal infections, birth asphyxia, and congenital malformations. So these are the killers in Western countries as well, but the proportion changes. There the deaths because of prematurity, as I mentioned earlier, are lesser as compared to the developing countries. Talking about India, around 13% of the babies that are born are premature babies. Okay, talking globally, there hasn't been much change in the number of babies that are born prematurely. Around one birth of every 10 births is a premature baby. And in Southeast Asian countries, as well as in the Western countries, preterm birth complications are the biggest killer or are the biggest chunk of under 5 mortality. What does under 5 mortality mean? All the babies that are dying till 5 years of age. So in India, the reason why under 5 mortality is high is because of preterm complications or complications of a premature baby. So globally speaking, around 20 to 30 million babies have some sort of preterm complications. Many of them die, and many of them are centered around Southeast Asian regions and definitely India, because of the volume of the population that is there in the country. So this is a rough statistics talking about prematurity and the causes of death in neonatal mortality and morbidity as well, because we do aim for survival, as a neonatal medical team or hospitals or infrastructure, but what we should really aim for is intact survival. What is intact survival? Is intact brain. So it's no point in only saving the babies for the sake of it, for the sake of life, but they should have a good quality life. And a good quality life comes with a good quality brain. And a good quality brain of a premature baby comes with good infrastructure, good handling, good team, and awareness. So everything is sort of interlinked when we are caring for premature babies or when we are caring for newborns who are at a risk of dying.
Correct. So again, awareness. For that, for example, I and my team are working on this report. So we need to conduct the surveys, like you said. So how many women are doing the ultrasound? Are they really aware these things, premature birth and all that stuff? So we are conducting the surveys for that as well in India, and for of course out of India we have a tie-up with other companies.
Okay.
So who can provide these kind of basic survey to us to finalize our report, Scopia report numbers.
Yeah.
So moving ahead. What are the key guidance and recommendation from WHO or UNICEF do you think are the most relevant?
Yeah, so I've actually, thanks for asking me that question, because I had written some things down. They are called as the Small Sick Newborn Care, that is SSNC, that require sort of 10 components, and these are the components that are declared by WHO and UNICEF. So what are these components? So they are health system approach, sort of the political commitment, then financing, HR, appropriate infrastructure, which is very important. Equipments and commodities, that is the fifth point. Then robust data systems. Why do they say robust data systems? For example, now we are working at the grassroots level, and strangely, after we started working over there in the grassroots levels in the rural parts of India, the newborn death seems to have gone up. So we are wondering that, we are doing good work. Why are the newborn deaths increasing? That just meant that we are picking the data better. We are reporting the deaths better. We are picking up the deaths that are happening, which were not reported earlier. So whenever any intervention has to be brought about by an NGO or government or anyone, there should be a baseline data which is robust, which is foolproof, and which is good data, which is good reporting of the data, and then a smart intervention will show whether your death rates or indicators have improved or not. That's why WHO and UNICEF says that robust data systems. Then you have referral systems, that is a part of ambulances. For example, ambulance is one part of a referral system. There is a whole different infrastructure, including communications between the two hospitals, between point A and point B, as well as the personnel that is taking the baby from point A to point B. So referral system does not only mean availability of an ambulance, so it means much more than that. Then eighth point is linking the high quality maternal care as well. We spoke at length about this earlier, that how important it is for girls or women in reproductive age group to take care of themselves in terms of physical health and mental health. The ninth point is family and community involvement. I spoke earlier about the family integrated care. Similarly, there is a big role of the community integrated care as well. And lastly, but definitely not the least, is the post discharge follow up, because once the newborn baby is discharged from the NICU or the neonatal care unit, that baby should be followed up by healthcare providers. Either the baby should come to the hospital, or the healthcare providers should devise a system that they can go into the homes and see whether the baby is doing fine as well. There can be a debate about the use of telemedicine, while catering to follow-ups, as well as taking advice from higher centers. So that's one point that companies can look into it, is making telemedicine available freely.
Correct. So right now, though, of course, telemedicines and mobile health, the market is growing.
It is,
because
yes.
after COVID, it is very necessary to this telemedicine and the
Absolutely.
mobile health is
Absolutely.
very necessary. So as you rightly said that the infrastructure is very necessary and it's very needed, and the thing is it's very important to it's like very plays a very important role to reduce the death mortality rate.
Yeah.
So what do you think, what kind of infrastructural upgrade, NICU capacity, equipment, staffing or referral system are mostly urgently to be needed?
Thank you. That's a good question, but I think it has a lot of elements.
Mhm.
So you asked me about infrastructure, staffing, and referral primarily. So let's talk about staffing. At the outset, yes, there should be trained staff, and training goes all around the clock. You train new nurses, the senior nurses train the junior nurses, etc. So that keeps on going. But having trained nurses, having trained staff is important, and having good numbers are also important. Generally in extreme premature babies in NICUs, there should be one-to-one nursing. In NICUs that are, let's say, level 2 or level 1, that is not so sick babies, 1 to 3 or 1 to 4 nursing is okay. So these numbers have to be achieved, and trained staff need to be hired and available, and same goes for the doctors as well. Same goes for physiotherapists, same goes for they call it class 3, class 4 workers as well, who's taking care about the cleanliness of the NICU. So it's not only singularly the doctors, singularly the nurses, it is the entire staff that is maintaining the hygiene, maintaining the cleanliness, making the medical equipments available where required, running in between the pharmacy and the NICU, etc. So all these minute details help save time, and in newborn care or newborn deaths and in neonatology, what anything can save lives is promptness, is time. So staffing is of pertinent importance. Trained staffing is of importance as well. Next, you spoke about infrastructure. So infrastructure, yes, varies depending upon what kind of neonatal unit, hospital, or the area has established. For example, the neonatal unit is caring for moderate to late preterms. Those are the preterms that are between 32 to 37 weeks of gestation. Then they can very well have less ventilators but more number of CPAP machines, more number of high flow nasal cannulas, more number of KMC chairs and KMC binders. So I think, to break down your question further, let me classify the premature period itself. That is moderate to late preterms, that is 32 to 37 weeks. In that, 32 to 34 weeks is moderate preterms and 34 to 37 weeks is late preterms. So they have different infrastructural need as compared to very preterms and extreme preterms. Okay, so very preterms are somewhere between 28 to 32 weeks of gestation. They will require ventilators and they will require CPAP machines as well. We have to customize and wean off the babies from ventilators to take them on CPAP or high flow nasal cannula. These are modes of non-invasive ventilation. That means you are not putting anything in the baby in an invasive form. What is that